Hello everyone, thank you for joining us this evening. I'm Dr. Lindsay Sharp, one of the bariatric surgeons here at RexBariatric Specialists. Tonight we'll be talking about obesity and the transforming effects of metabolic and weight loss surgery. Our program here at Rex has received numerous distinctions, including Center of Excellence from the American Society for Metabolic and Bariatric Surgery, as well as Blue Cross Blue Shield Blue Center of Distinction. Tonight we will be discussing common myths that are out there around bariatric surgery. We'll talk about obesity as a disease and describe how it really has its tentacles in every organ system in our body. We will discuss the science of weight loss as we currently understand it and really kind of talk about why it's difficult to lose weight in general. We'll show some neat cartoons of the different bariatric procedures and give you some facts on expected outcomes. And then we'll wrap up the discussion with a description of how we prevent complications and then describe what is the steps to get to surgery from where we are today. These are some of the myths that we've heard through the years that seem to be a recurring theme regarding bariatric surgery. One myth is that bariatric surgery is cosmetic surgery. The reality is that what we do is the most effective treatment for not only obesity, but many related diseases such as type 2 diabetes, high cholesterol, and even potentially reducing the risk of heart attack and stroke. And we'll get more into that in just a bit. Another myth that we hear is that the formula is simple. Why don't you just eat less and exercise more? And unfortunately, obesity is a very complicated disease. It has a lot of different factors that play into it, including your genetics, things you can't control, including your job. Maybe you work all night, and so your eating habits are disrupted because of that. There are cultural issues that can contribute. For example, many of us celebrate any kind of good news with food, or even mourn when someone dies. Oftentimes we will bring them food. So there are many factors that play into obesity, and it's not as simple as, just eat less and exercise. Another myth that we hear all the time is that, patients who have surgery are taking the easy way out. And if you actually talk to anyone who's had surgery and has been successful, they'll tell you that the surgery itself is probably the easy part of the process. Nowadays, most patients are spending 1, maybe 2 nights in the hospital, back to work in 1 to 2 weeks. So that part of the process is fairly simple, but it really does take a lot of work to be successful long term. You do have to change your eating habits and your activity level to maximize your success. And so we're here to help provide those tools to you as well. And then the last myth is that bariatric surgery is very dangerous. And I always like to think of this in terms of weighing the pros and cons. So, I think there is risk to anything we do in life, and while there is some risk related to surgery, it's actually the benefit of surgery far outweighs that risk, both in terms of improvement in health, but also in terms of improvement in quality of life. And we're going to show you some statistics on this a little bit later. So how do we measure obesity? Well, the most common term we use these days is body mass index, or BMI. And it's basically taking your weight and dividing it by your height in meters squared. Or more simply, if you go to Google and type in BMI calculator, you can find 100 pages where you can put your height and weight in and know exactly what your body mass index is. This allows us to develop tables like these to identify people who are considered to be in the healthy weight range, which is a BMI of 18 to about 25. People are considered to be in the overweight range when your BMI is 25 to 29. And we really start to define obesity as having a BMI above 30. And we use these different BMI ranges to identify which treatments are available to each individual. So currently, if your body mass index is 35 and above and you have medical problems related to obesity, such as high blood pressure or diabetes or sleep apnea, heart disease, just to name a few, then you would be considered a candidate for surgery because the benefit of surgery far outweighs the risk in this situation. Now, if you're in a lower BMI range, maybe 25 to 29, this might be where we recommend considering perhaps some weight loss medications in addition to diet and lifestyle modification. In the future, we'll likely see surgery expanded to the class 1 obesity or BMI of 30 to 35, particularly in people who have type 2 diabetes, because we have such a tremendous tool to help people stop the diabetes early on in the process, perhaps even with a less aggressive surgery. So obesity is really an epidemic. In our country, the rates of obesity have really skyrocketed over the last 30 years. Currently, the rate of obesity in the United States for adults is at least 25%. And if we look at the southern states here in red and in maroon, those states have at least 1 in 3 individuals in those states have obesity. So that's a pretty staggering number. And if we look at children or adolescents over time as well, back in the 60s, the rate of obesity was around 5%. Nowadays, on average, it's around 15%. And the challenge with this is that kids who have obesity then go on to be adults who start developing those medical problems at a much earlier age. So you have 30-year-olds who are developing diabetes or getting put on high blood pressure medicine. You have 40-year-olds who are needing knee replacements, whereas in the past, 30, 40, 50 years ago, these were all diseases that people didn't see until much later in life. So unfortunately, North Carolina is one of the states where the rate of obesity is roughly 1 in 3. That means obesity is very, very common in our state. And if trends continue as they are, in our population, the rate of both people who are overweight and obese combined is going to exceed 60%. So 2 out of every 3 individuals either have obesity or are on their way. And obesity kills a lot of people, as you can see. It's now the second leading cause of preventable death in the United States, behind smoking, which is number 1. And it's very expensive. The estimates on the cost spent for obesity are on the low end at $149 billion, but maybe upwards of $200 to $250 billion a year spent on obesity. So I want to thank you guys for your attention. And at this point, I'm going to pass the microphone to Dr. Nong, who will take us through the metabolic syndrome as well as the science behind weight loss.
Thanks, Dr. Sharp. When we refer to metabolic syndrome, we're referring to the impact of obesity on our organs. From head to toe, every organ system can be impacted negatively, but we also know that if we help people lose weight, we can help reverse disease. In fact, we know that their quality of life can improve significantly, and of equal importance, we can help you live longer, reducing your mortality risk by 89% in the next 5 years. In fact, when we talk about risk of obesity, there's a direct correlation to your risk of death with your increasing BMI. When your BMI reaches 40, you're at nearly a 2.5 times increased risk of mortality. And by the time it reaches a BMI of 50 or super morbidly obese, you're at nearly a 4 times increased risk of mortality. So when we talk about weight loss and trying to understand why it's difficult to lose weight, one of the important concepts to know is the set point theory. In effect, each of our bodies has a thermostat for weight, which controls our ability to lose or gain weight. In fact, it makes it often difficult to lose weight. This bariostat, if you will, is managed by several important hormones in our body, or what are called neurohormones. This is affected between your small intestine, stomach, pancreas, and peripheral fat with signals to your brain either telling you you're full or telling you you're hungry. And this regulates our energy expenditure and controls our weight. When we talk about hormonal weight regulation, we're really talking about the gut hormones sending signals to our brain telling us we're either hungry or full. When we go on a diet, it's not surprising that the hormones that normally make you feel full are suppressed, and the hormones like ghrelin that make you feel hungry are turned on. The opposite happens with surgery. What we see with our various operations is an increase in the hormones that make you feel full, giving you that sense of satiety, and suppression of the hormones that make you hungry. And this is why when you lose weight after surgery, it's not around discipline and willpower, but it's a biologic change in your sense of hunger. I'll now have Dr. Youngworth talk about the bariatric techniques.
Next, we will be discussing the bariatric techniques. Bariatric surgery works by three fundamental concepts: restriction, malabsorption, and hormonal. Restriction, meaning that you're not able to eat as much as you were before surgery. Malabsorption, meaning that you're not absorbing as many calories or as much fat as you were before surgery. And hormonal, meaning the hormonal changes that were discussed earlier. The first surgery that we will discuss is the laparoscopic sleeve gastrectomy. All of the surgeries are done laparoscopically with the tiny little incisions, as you can see here. We then place trocars so we can place and remove instruments as necessary. All of the surgeries are done under general anesthesia, so you're completely asleep for all of the operations that we perform. The first part of this video is going to go over normal anatomy before surgery. As you can see, food is simulated in blue, entering from the esophagus into the stomach and then to the first part of the small intestine, where it mixes with the green, which is the digestive enzymes. With the sleeve gastrectomy, what we do is we place a sizing instrument and then we staple along that sizing instrument, removing the lateral portion of the stomach. So again, after surgery, the food will be simulated in blue and the digestive enzymes in green. The food comes down the esophagus, enters that sleeve stomach, and then slowly enters into the small intestine where it mixes with the green, the digestive enzymes from the liver and the pancreas. With the sleeve gastrectomy, on average, we see approximately 55% excess weight loss at 1 year. There is no small bowel intestinal bypass, so this operation relies only on restriction and the hormonal benefit. There's also less nutritional deficiency. While this is the most commonly performed operation in the United States currently, we actually have the least amount of experience with this operation. The sleeve gastrectomy is irreversible, and it also poses some unique risks, including reflux and stenosis. The next operation is the Roux-en-Y gastric bypass. With the laparoscopic Roux-en-Y gastric bypass, we don't remove any of your stomach. Instead, we disconnect the upper portion of the stomach from the lower portion of the stomach, creating an upper stomach pouch. We then divide the small bowel, bringing up the distal end to that gastric pouch and making a connection between the stomach pouch and the small bowel. Another connection, or anastomosis, is made between the small bowel and the small bowel. The food is simulated in blue, the digestive enzymes from the liver and the pancreas are simulated in green, and as you can see, they will meet up at that second connection. On average, with the Roux-en-Y gastric bypass, patients can expect approximately 65% excess weight loss at 1 year. This is the operation that's been around the longest, and because we're performing a small intestine bypass, this operation relies on all three fundamental concepts, including restriction, hormone benefit, and malabsorption. There are some unique risks with this operation, and the one that I'd really like to highlight is marginal ulcer. And that's an ulcer that forms on that connection between the gastric pouch or the stomach pouch and the small bowel. This is particularly bothersome in patients who smoke and in patients who take NSAIDs, including Motrin and ibuprofen. The next operation is the laparoscopic single anastomosis duodenal ileostomy with sleeve gastrectomy, or SADE. The SADE is done laparoscopically, as are all the procedures that we perform, but the SADE is a combination of a sleeve gastrectomy and a small intestine bypass. So the first part of the video will see us removing that lateral portion of your stomach, just like the first video we showed you. But then we will divide the first part of your small intestine, or your duodenum, approximately 3 centimeters beyond your stomach. We will then measure your small bowel approximately 3 meters from your colon and make a connection between that small bowel and the duodenum. It's at this connection where the food will meet up with the digestive enzymes from your liver and your pancreas, as seen here on the right. With the SADE, on average, we see approximately 75% excess weight loss at 1 year. This operation relies on all 3 fundamental concepts, including restriction, the hormonal benefit, and malabsorption. This operation is a little less potent than the next operation I'll talk about, which is the duodenal switch. And given that, this operation has less malabsorption than the duodenal switch. This is the newest procedure, and because of that, not all insurance companies cover this procedure. The next operation is the laparoscopic duodenal switch. The duodenal switch is a sleeve gastrectomy with a small intestine bypass. The lateral portion of the stomach is removed, just like in a standard sleeve gastrectomy, but then the duodenum, or the first portion of the small bowel, is divided, as is the ileum, or the last portion of the small bowel. The distal portion of the small bowel, or small intestine, is brought up to the duodenum, and a connection is performed, or an anastomosis, between the duodenum and the small bowel. A second connection is performed more distally so that the food can meet up with the digestive enzymes. The food is demonstrated in blue, the digestive enzymes from the liver and the pancreas are demonstrated in green, and they meet up at that second connection. The portion of the small bowel that sees both the food and the digestive enzymes is referred to as the common channel, and this is where absorption occurs. The duodenal switch is the most potent operation. On average, at 1 year, patients experience approximately 85% excess weight loss. This is also the best operation for long-term weight loss, and we see approximately 80% excess weight loss at 10 years. This is the operation that we recommend for patients with a higher BMI as well as type 2 diabetes, because we see up to 98% remission of type 2 diabetes. There are some unique risks with this operation, including diarrhea, fat-soluble vitamin deficiency, and protein deficiency. However, these risks are minimal if patients follow the high-protein diet and take their vitamins after surgery. This chart demonstrates all the tools in our toolbox, from medications to surgeries, on a continuum with weight loss increasing from left to right. After completing this seminar, you will be set up with a one-on-one consultation with one of us surgeons. In that meeting, we will discuss your past medical history, your past surgical history, and your current BMI. We will also discuss your goals for bariatric surgery. Together, we will come up with a plan that best fits your unique story.
Well, this is a very exciting process to potentially eliminate a lot of medical conditions that you have and improve your overall health. But it's also potentially a very scary one. I will tell you that we've come a long way when it comes to complications and challenges in the post-operative period. But we're going to go over in a bit more detail about possible issues that you may contend with after surgery. If you look at this national data, we can go over in more detail about several different possible issues you can contend with after surgery. Fortunately, these complications and issues are quite rare, especially here at Rex, where if you look at our data, we are at least a half, if not a quarter, of these numbers when it comes to complications after surgery. Specifically, the most important technical issue that one can have after surgery is that of a leak. A leak can occur at any anastomosis or connection, such as with the gastric bypass, SADE procedure, or duodenal switch. You can also theoretically have a leak after a sleeve along that staple line. The important thing that we want to stress to you is that here at Rex Bariatrics, the only people who will ever be on call for any emergency or urgent issue with you are your bariatric surgeons. The nurses on the floor who are going to take care of you are specifically trained to take care of bariatric patients, and they're experts at identifying the early signs and symptoms of a leak. Fortunately, when we perform these operations, we test every single patient in the operating room to confirm that they do not have one at the time of the operation. And we do not perform upper GIs or swallow studies afterwards because the provocative leak test we do in the operating room is so precise and sensitive. Another issue that you may contend with after surgery, which again is fortunately quite rare, is that of a PE or DVT. A DVT is a deep venous thrombosis, which is a blood clot almost always in your leg. And a PE is a pulmonary embolus, which is a blood clot that starts in the leg and ultimately ends up in one of the arteries of your lung. This can lead to a very low oxygen level and is obviously a very urgent issue that needs to be addressed. Fortunately, we have implemented a very aggressive regimen here at Rex to prevent that complication. Everyone before surgery receives an injection of what's called heparin, which is a blood thinner that really is the most effective way to prevent the development of blood clots. After surgery, within about 4 hours, we actually have you up and walking. And finally, everyone has a sequential compression device, or SED, which is a device placed on your calf to help blood from pooling. In the general sense, probably the most common issue that one can contend with after surgery is that of dehydration and nausea. Those two issues certainly go hand in hand. Once somebody starts to develop some nausea, you're a lot less inclined to drink. And when you're less inclined to drink, you become more dehydrated, which then can make that nausea even worse. We've implemented a series of programs with our division to minimize that risk. One of them is the Enhanced Home Health Program, where we can provide a nurse to come out to your house and give you additional IV fluids to help make for a smoother transition from the hospital to your home. When you look at the complications that one can have after bariatric surgery, we've come a long way over the last 30 years. If you look at the risk profile of undergoing a bariatric procedure in 2022, in most respects, it's actually safer than undergoing gallbladder surgery. If we were talking perhaps 20 years ago, the risk profile was on par with hip replacement or possibly even heart bypass surgery. Bariatric surgery truly changes people's lives. People no longer have to take medications for diabetes. They may be able to move faster and without pain in a way that they never could before. But it is a journey, and it does involve a great deal of hard work. In the end, we perform hundreds of surgeries every year, and we perform them very safely. But even with the most perfectly performed surgery, it is really important to still look at this as a tool for your overall health. It really does take a village to ensure that you are successful, not just leading up to surgery, but also afterwards. I feel that we have an outstanding practice here that really provides outstanding comprehensive care for you, both leading up to and after the operation. We have A physician who specifically specializes in medical weight loss, should that be necessary at some point down the road. We have 5 dietitians who specifically take care of just people who have had or will be having bariatric surgery. We have 2 full-time psychologists who just take care of bariatric patients. We have personal trainers, and we have a number of other support groups and support systems available to help ensure your success in the long term. One of the other things that we really pride ourselves on here at Rex Bariatrics is lifelong surveillance. While other practices may bring you in and perform a good operation, it's really important to look at the lifelong upkeep. And so we really encourage our patients to see us not just at the 2-year mark, but at the 5-year mark and the 10-year mark. We really want to intervene if we start to see any issues with you after surgery. If you happen to have any weight gain or vitamin deficiencies, we want to intervene ahead of time and still waiting for you to have a major problem down the road. We encourage you to really consider this as the first step on your journey to lifelong weight loss. We encourage you to stay committed and to embrace this journey, to begin to start thinking about ways to change your daily routine, to incorporate some exercise, as well as make some changes with your diet to ensure that you have a relatively low-fat and low-sugar diet. And we will go into more detail about that once you begin our first nutrition class. Now that you've completed this initial seminar, we're going to give you a call within the next 1 to 2 days to set up 2 separate appointments for you. The first step would be a one-on-one consultation with your surgeon, and in that session we'll discuss in more detail your history and what your expectations are in terms of goals. We'll also talk a little bit more about any risks related to the operation. Secondly, we'll also set up your first nutrition class, which is what we consider to be an orientation class. In that class, we will give you a large handbook that goes into a lot more detail about your nutritional requirements after surgery. But we'll also go into more detail about some of your insurance authorization and requirements with your particular plan. At that first class, we will have already gone through an evaluation of your insurance plan to give you a sense of how much surgery might cost you and what the waiting period might be.
On behalf of my partners at Rex Bariatric Specialists, thank you for taking the time to review this online seminar. We look forward to seeing you in the near future and working with you towards your journey. Thank you.